After more than 40 years of calling it Polycystic Ovary Syndrome, medicine has finally given this condition a diagnostic label that tells the absolute metabolic truth. On May 12, 2026, the global medical community officially retired the name PCOS and replaced it with PMOS, which stands for Polyendocrine Metabolic Ovarian Syndrome. This is not a superficial semantic tweak. It's a massive structural shift in how we understand exactly what is happening inside a woman's cellular blueprint. The old name kept everyone obsessed with cysts on the ovaries that were never true pathologic cysts to begin with. The new designation, PMOS, accurately maps out three core systemic realities. First, the word polyendocrine recognizes that this is a multi-system hormonal disruption that ripples across the entire endocrine network, far beyond just estrogen and progesterone. Second, metabolic places insulin resistance and cellular energy dysfunction right where they belong, directly at the center of the entire disease mechanism. And third, ovarian preserves the reproductive features of the condition without allowing a single pelvic organ to narrow the scope or define the entire syndrome. This fundamental reframing changes the entire game. It moves us away from treating isolated surface level fragments of the problem and forces us to address the whole body systemic reality. PMOS finally centers what clinical data has shown all along: a highly complex, self-reinforcing interplay of hormones and metabolism that impacts a woman's health long before and long after her reproductive years. For any woman who's had to live with this condition, transitioning the label Polyendocrine Metabolic Ovarian Syndrome fundamentally rewrites how we approach clinical diagnosis and long-term care. When we examine the term polyendocrine, we are acknowledging a complex, multi-layered web of hormonal axes. Androgens, insulin signaling, adrenal output, neuroendocrine regulation, and ovarian function do not operate in a vacuum. They interact in highly intricate bidirectional loops. The inclusion of the word metabolic is the critical missing piece of the puzzle that clinicians ignored for generations. Insulin resistance sits dead center in this entire physiological mechanism. In fact, clinical data reveals that as many as 88% of women dealing with this syndrome exhibit measurable alterations in insulin metabolism. Whether that manifests as impaired cellular sensitivity, reduced hepatic clearance, or chronic oversecretion from the pancreas. When circulating insulin levels are chronically elevated, it acts as a massive upstream driver. High insulin directly stimulates the ovaries to overproduce androgens. At the very same time, it suppresses the liver's production of sex hormone-binding globulin, which allows far more testosterone to circulate completely free and unbound in the bloodstream. This free fraction is what triggers the classical symptoms of tissue androgenization while feeding a continuous cycle of low-grade cellular inflammation. The word ovarian is still there, keeping the reproductive dimensions like irregular ovulation or the arrested follicular patterns we see on ultrasound properly recognized. But it ensures we are no longer reducing a profound multicystic syndrome to a single organ or a single life stage. This new name doesn't just describe the pathology more accurately, it invites both clinicians and patients to stop chasing symptoms with synthetic hormone blockades and start rehabilitating the root metabolic drivers.